the we are excited to bring you the subspecialty morning report today, and we are privileged to have with us two fantastic clinician educators with us, Dr. David Lee and Dr. Dana Larsen. And I will let them introduce themselves because it's going to be great.
Awesome. Thank you. I'm going to introduce my colleague, Dr. David Lee, who's going to be responding to the case that I present today. He is a medical educator and nephrologist here where I'm at UCSF in San Francisco. And his main focus is in electrolytes and palliative nephrology at this point in time. Outside of medical education, he loves being outdoors and doing some reading as well.
Okay. Thanks, Dana. Dana is also a nephrologist and medical educator here at UCSF Nephrology. She has a particular research interest in FOMED, free open access medical education, which is exactly what Clinical Problem Solvers is. So it's very fitting. And outside of the hospital, she is a very avid soccer player and a big sports fan. And we're both very happy to be invited here.
Perfect. Pleasure. Yeah, pleasure is all ours. Thanks for coming to the meeting. And I was just going to say, I was talking to Dana before the meeting started that we love the kidney beans, the way the pathophysiology is organized in the body in terms of how kidney functions is so fascinating. And we are so excited for today's session, and we will surely be learning a lot of pathophysiology from today. So Dana, whenever you are ready, let's start with the first Sally-Code.
Yeah, absolutely. So I hope we don't disappoint because we're taking a kidney that has failed today as an initial starting point. But our chief complaint is going to be altered mental status in a patient on peritoneal dialysis. So something that maybe you guys may not have encountered all the time, and kind of the way that us as nephrologists think through it. So her HPI is a 74-year-old woman. She has ESRD that's presumed due to hypertension, and she's on CAPD, or continuous ambulatory peritoneal dialysis. And she comes into your clinic with cloudy effluent in the setting of increased forgetfulness when her family told her you better get into the clinic. Her increased forgetfulness for her family is characterized by a lack of independence in performing her PD exchanges. I have additional HPI that we can give. I'm curious if, because peritoneal dialysis is a little less familiar of a topic, we want to have David kind of walk us through peritoneal dialysis and some of just kind of what it is and what we expect patients to be doing, and what her lack of independence in doing it might be.
Yeah, thanks, Dana. So there's two big main forms of dialysis, kidney replacement therapy. One of them is hemodialysis, where blood is drawn from the patient, usually from a fistula or graft, just a blood connection in their arm, or through a catheter in their chest or their neck. And then when blood is run through the machine, it's run through a synthetic filter, and toxins are cleared out, electrolytes are managed, volume status and water balance is managed. With peritoneal dialysis, fluid is run through a catheter that goes directly into the abdominal cavity. And the filter is the patient's own peritoneal membrane. And similarly, it manages water balance, electrolytes, helps clear toxins, and then the fluid is removed. The benefit of peritoneal dialysis, people tend to have a lot more independence. They can use it to adapt to their own work schedule. And then another benefit too, peritoneal dialysis is done during the day, over at night, throughout the week, as opposed to hemodialysis, which is usually done a few times a week. So if you're doing something every day, it's easier to manage volume status. And also, people tend to have less swings with uremic toxins building up before a dialysis session than clearing it all at once. So they tend to feel better too.
Awesome. Thanks, David. Okay, I'm going to give the rest of the HPI then, and then I'll pause after that. So she was sent in by her family, essentially, because of the lack of independence with her PD recently. In her history, she had recently traveled to Las Vegas from San Francisco. She lives in San Francisco, and she had been there for a couple of weeks visiting family. When she returned, her other family here noticed that she was more forgetful, and they described that as like she's just forgetting to do some of those dialysis exchanges during the day that David was talking about, when usually she's very compliant with her peritoneal dialysis, doesn't miss any sessions, is good about taking all of her blood pressure medications and so forth. And then when she comes into PD clinic, she comes in with a son, and the peritoneal dialysis nurses actually perform an exchange for her while she's there, and they notice that the PD fluid is cloudy. For review of systems, I'll do as well, unless you want me to pause before that.
I think we can have review of systems. Yeah.
Okay, so her ROS is actually negative for abdominal pain, fevers, no chills, no nausea, vomiting, no diarrhea, and no constipation.
Perfect.
If I was seeing someone like this in clinic, altered mental status, the initial differential for this is usually pretty broad. Toxins, metabolic derangements, infections, structural things going on in the brain. Out of those, her history of cloudy dialysate raises a big concern for infection, in particular infection in the abdomen, peritonitis, which is a fairly common thing that can happen in patients on peritoneal dialysis, because there's fluid going in and out of their abdomen multiple times throughout the week. So I think for this person, usually, if I was seeing her, is it the most common complication? Deborah asks this. Peritonitis is the most common infectious complication with peritoneal dialysis. Yes, it is. Similarly, for in hemodialysis, the most common infectious complication, or the more dreaded one, is bacterial bloodstream infections, like bacteremia. Okay. And, so if I was seeing this person in clinic, I would check a BMP, UA, CBC with differential, and then I would also draw the peritoneal fluid for cell count with diff, gram stain, and then she seems decently symptomatic with her confusion, and she also has at least clinical signs concerning with cloudy dialysate. So I would give her a dose of empiric antibiotics while we wait for the cell count and differential to return.
And Dr. Lee, before we hear the next report from Dana, I wanted to have your opinion on one very important question that we face in daily life, that we see these people who are getting dialysis and who come with cloudy dialysate, and there's concern for peritonitis. But then we ask ourselves that, is this altered mental status coming from uremia itself because of missing the dialysis or having less frequent dialysis, or is it due to the peritonitis itself? So are there any clinical clues or the mechanisms through which we can think through this dilemma?
Oh yeah, so that's a great question. So uremia, there's two pretty good learning points there. One, uremia is a clinical diagnosis that's also often a diagnosis of exclusion. So physical exam findings that can be more consistent with uremic encephalopathy are things like asterixis, for instance. If you check her physical exam and have her hands out, is there some flapping? Other physical exam findings that are more consistent specifically with uremia are things like dysgeusia, where you have a strange metallic taste in your mouth, food tastes differently. Sleep-wake disturbance, where people are really awake during the night, but then fall asleep very frequently during the day. One useful way to look at a BMP, you can look at the BUN, blood urea nitrogen, and look at past BUN to see if it's much higher than where she normally runs. The caveat to this is, BUN on a lab is a laboratory marker for specifically urea, and we use it as a surrogate marker for unmeasured uremic toxins, which we have no way to measure. So there isn't a specific BUN number that says someone definitely has uremia, or they definitely don't have uremia. But looking at prior trends can be a helpful clue.
Perfect. Thank you so much for sharing those thoughts. Dana, we can move ahead.
Okay, great. So her past medical history, so she has ESRD due to hypertension. She also has a history of hyperlipidemia, and then had latent TB that was treated a decade ago with moxifloxacin followed by rifampin. Surgical history, which I don't see that you guys had there, but it was just her PD catheter was inserted about 8 years ago. Social history, she lives with a son and a daughter in San Francisco. They don't have any pets. She grew up in Vietnam and immigrated to the US as an adult. Never any smoking or IVDU history. Family history, notable for hypertension on her mother's side. No other pertinent family history. No allergies to medications. And I have her medications. I'll wait for you to catch up a second. For her medication, she's on losartan 25 milligrams daily, methotrexate 25 milligrams daily, atorvastatin 40 milligrams, calcitriol 0.5 micrograms daily, a renal multivitamin daily, and darbepoetin 40 micrograms twice a month. I can repeat any of that needs to, sorry.
And I think, Dana, you can give us all the information till physical examination, and then we can pause.
Okay, fantastic. So I'll continue. For her vitals, she was afebrile, heart rate was 87, respiratory rate was 21, blood pressure was 110/60, and she was on room air. For exam, she, as many of our dialysis patients, kind of chronically ill appearing, but not acutely ill. Her AT&T was largely unremarkable. For her cardiovascular, it was regular, rate and rhythm. Home-wise, she had clear lungs. Her abdomen notably was soft, non-tender. The PD catheter site had no erythema, induration, or tenderness. And then neurostata, she was fully oriented and had no evidence of asterixis.
So, Dr. Lee, what do you think that how can we integrate the past medical history, this medication list, and the relatively normal examination findings into our chief complaint?
Yeah, so to summarize, to give like a one-liner, we have a 74-year-old lady with a past medical history of ESRD, presumably from hypertension, on peritoneal dialysis at home. Other history notable, let's see, she immigrated from Vietnam and has history of latent TB, treated, who's presenting with a few days of altered mental status, worsening confusion, and cloudy dialysate. The review of systems is negative for constipation, which is very helpful, particularly in PD patients. Constipation is the most common cause of inadequate peritoneal dialysis, just because you need good peristalsis in your gut to have the peritoneal dialysis membrane working well to make sure it's transferring things. So in the absence of that, cloudy dialysate, altered mental status, peritonitis is the most concerning thing, like I said. So the best way to look for that would be to get fluid from the peritoneal dialysate. Ideally, it has to be at least 1 liter total, and it has to have been sitting in her abdomen for at least 2 hours. And then if you take that fluid, you can send a cell count and differential. And things you're looking for, a white blood cell count greater than 100 per microliter. And usually that's with greater than 50% PMNs, polymorphic neutrophils. And then you would also send the fluid for gram stain and culture to see if you're able to see any organisms or if any organisms can grow out. And then, yeah, looking for other things. If she's still peeing, a UA and a urine culture to rule out UTI. It doesn't sound like physical exam is concerning for pneumonia. It doesn't sound like on the history she's had any new medication changes or ingestions. And then, yeah, you can get a BMP and compare the BUN to prior BUNs, which can, if she has worsening azotemia, which is a higher BUN from prior, that can potentially be a clue that the altered mental status can be uremia. So it doesn't sound like she has other signs of uremia like asterixis, dysgeusia. Yeah. Somnolence would be another one.
Perfect. Thank you, Dr. Lee, for highlighting the important points that we have to look. And I also wanted to quickly pick your brain on one important thing which you mentioned. As you said that the thing we are looking for in peritoneal fluid is about 100 WBCs per millimeter cube and 50% of them being PMNs. Now, I wanted to ask that when we diagnose other forms of peritonitis, does the cutoff vary, or like what's the mechanism behind the cutoff being different for different kinds of peritonitis?
Yeah, no, that's a very insightful question, and also something I noticed. I honestly think the difference is historical, just to whatever societies were first investigating peritonitis in this population started off with a different branch point than, for example, spontaneous bacterial peritonitis in cirrhosis patients. So you have, it's slightly different, yeah. For cirrhosis patients, it's greater than 250 PMNs total, yeah. Whereas this one, it's greater than 100 all white blood cell count total with greater than 50% PMNs. Yeah, slightly different. I honestly think it's just historical.
Sure. That does make sense. Yeah. Perfect. So, Dana, why don't we have some more data?
Sorry, I had muted myself. Yes, absolutely. So in terms of her labs, her white count was 12. Sorry, I read the wrong number. Her white count is 6. Her hemoglobin is 10. And her platelets are 270. Chemistries, sodium is 134. Potassium is 3.5. Fluoride 89. Bicarb 23. BUN 77. Creatinine is 11. Glucose is 120. I don't think we had a calcium magnesium that was drawn right then, nor did we draw LFTs or troponin. I don't have our GFR, but it'd probably be around 3, would be my guess. We also did none of that imaging.
Dana, do you think that we will have some more data before we stop? That would be
I was
better.
gonna say, I do also have the peritoneal dialysis data if you want that right now too.
Sure.
Yep. So our dialysis, there was a cloudy appearance. The white cells were 187 cells per cubic millimeter or microliter. There were 27% neutrophils. The gram stain was negative. Bacterial cultures were sent and they're currently in process. And I have sort of extended data as the case continues to evolve from here. So I'm going to pause for here for right now, if that sounds good.
Perfect. That's good. So,
Yeah, you know, the labs, you may notice the creatinine is very high. In hemodialysis patients, they tend to get more aggressive clearance when it happens 3 times a week. And often in that setting, you'll see that the creatinine will rise before dialysis session, acutely drop during that dialysis session, then slowly rise past that. The number itself doesn't really mean anything. It just reflects how far away or how soon they were with their last dialysis session. In peritoneal dialysis patients, a lot of their clearance ideally is managed partially by the residual urinary output, and then the rest of it you augment with peritoneal dialysis, and together it gives them all the clearance that they need to not have many symptoms from the peritoneal dialysis, from their ESRD, from their kidney failure and stage renal disease. So often in peritoneal dialysis patients, you may see higher creatinine numbers in and of itself, but as long as they're symptomatically not having signs of uremic toxins buildup, really high phosphorus, other signs of decreased clearance, it's fine that a creatinine number might be high. Yeah. But you know, the PD fluid, the white count, why was it 187?
Correct.
Yeah.
187.
Yeah, 187's definitely above 100. The percent neutrophils isn't greater than 50%. So kind of half criteria. But that plus for clinical findings concerning for peritonitis, which are her altered mental status in the setting of cloudy dialysate, which it shouldn't be cloudy. It should be clear usually. That is concerning enough for spontaneous peritonitis that I would treat her, seeing these findings. And then yeah, clinically it doesn't sound like she has something else like a pneumonia or something. So treatment wise, if I was seeing these labs in clinic, and she's otherwise well appearing and enough to stay outpatient and not need to be admitted, which are things like hemodynamic stability, for instance, general appearance on physical exam. Oh, you know, yeah, then it's also very important too that PD catheter site, there's no erythema, induration, or tenderness, because that can be concerning, for instance, if there's erythema at the exit site, that can be a sign of a superficial soft tissue infection, and then tenderness or induration along the PD catheter tract as it's following and entering the abdomen, that can be a sign of catheter site infection too. And then that combined with peritonitis makes you more concerned that potentially there's like an abscess or a fluid collection that might need procedural intervention. But in the absence of that, it sounds like she could be managed outpatient with antibiotics initially. Yeah. So the first antibiotics, usually we do gram-positive coverage, something to cover skin flora that might have been introduced during a non-sterile exchange, and then gram-negative coverage to cover something that might have had gut translocation, for instance. So common antibiotics would be vancomycin, ceftriaxone, or vancomycin cefepime. And usually this is given into the peritoneal cavity. So you can add it into the bags of dialysate, which is the fluid you instill into patients' abdomens for peritoneal dialysis. And then they dwell it in their abdomen and then drain it. And then the antibiotics are given directly where you have the active infection. And yeah, it also, if she's getting antibiotics, and this is true for not only antibiotics in the peritoneum, but systemic antibiotics like oral antibiotics or IV antibiotics, because she's a peritoneal dialysis patient and they rely on their gut flora to help prevent fungal infections, giving them antibiotics puts them at higher risk for fungal peritonitis in the future as a consequence of just getting antibiotics. So all these patients should also be given antifungal prophylaxis. It's really important with either nystatin or fluconazole are the common ones. and that's given during the antibiotics and then 1 week afterward for any antibiotics that are longer than a week course, say. So yeah, probably in our clinic, just because we have a high Pseudomonas prevalence in the community, she would get Vanc cefepime intraperitoneally, and then antifungal prophylaxis. Probably fluconazole, just because it's easy to take once a day as opposed to nystatin, which is 4 times a day. Though you do have to look for med interactions with fluconazole. And then she'd be given return precautions, like make sure the mental status is getting better, the dialysate is clearing up, and then would be seen back in a few days as a PD nursing visit to check the fluid, make sure it's clearing up, check the cell count, and make sure the cell count is downtrending.
Perfect. Thank you so much, Dr. Lee, for not only introducing to us how to, interpret all these studies, but also thinking 2 steps ahead of like what are the management paths. And I personally didn't know about this antifungal prophylaxis, because in people with neutropenia, we always think about that, but in peritonitis, somehow it evades our mind. So thank you for highlighting that point. And I was also curious to know from you that given that we have gram stain, which is negative, and this past medical history of like suspected TB, which was treated, do you think it has any bearings on how we interpret the gram negative findings, or is it something which can often come up?
Oh, no, that's a really good point. You know, a negative gram stain, the gram stain in and of itself isn't necessarily sensitive. It'll be important to follow up on the culture. If the gram stain is negative and the culture is negative, that is a fairly frequent thing that we see. A good chunk of the time in PD patients with peritonitis, you don't always have a positive culture that gives you the exact culprit. When that happens, we call it culture negative peritonitis. If she's clinically improving, like the white blood cell count is downtrending, the dialysate is clearing up, and her mental status improving, just on antibiotic coverage, then you can presume that it was a bacterial infection that you just weren't able to grow. And then usually that person, if they're improving, they would be narrowed to just gram-positive coverage to cover presumed skin flora and finish out 2 weeks if they're clinically getting better. If she's not getting better, you have the negative gram stain and the bacterial culture stays negative, but the white count in the peritoneal dialysate fluid is still rising. She's still getting confused. She's having worsening abdominal pain or something. Then that person, you would look for things that are potentially more fastidious, like TB. You would get abdominal imaging to make sure that there isn't an abscess you're missing. And that you can send, that person, you would repeat cultures and try to get more fastidious things like fungal cultures, AFB cultures. For her, you could get a TB PCR, for instance, too.
Perfect. That does make sense at how response to the treatment can guide us. Thank you, Dr. Lee. Dana, we can have some more data.
Awesome. So I think to highlight here is we have a strong suspicion for peritonitis, but doesn't probably quite meet diagnostic criteria, but we're treating prophylactically, which is great. But in those settings, we oftentimes bring the patient back to clinic pretty close and have the nurse to follow up. So on day 2, the patient was brought back to clinic by the son, I believe it was, family member that had noted that she had been more altered. And it was noted that her mental status is about the same. They have been compliant with doing the peritoneal dialysis exchanges at home, and the volume of fluid that they were getting back all seemed to be working just fine. Still no abdominal pain. They noted that when the nurses exchanged the fluid in the office, the fluid was still cloudy. And they sent it again for the same cultures, gram stain and cell count. And this time it found that her white blood cell count was 88 cells per cubic millimeter. And then she had 40% neutrophils. Her prior cultures were reviewed, and these were still no growth to date. And because of the persistently cloudy fluid, they decided to send fungal cultures at this time as well. I can pause or I can keep going with additional follow-up.
I think then how much more data do we have?
We have through day 21.
Oh, and you have like for each and every day, you have different
Oh,
data?
we don't have each day. No, we don't have every day. We have just a few days. I probably have 4 more days worth. So this
Okay,
is kind of the first step.
Yeah,
I
we can
did
have
like-
one more day. We can have one
Okay,
more
we'll
day.
do one more. Thank you for counseling me on how to present my patient. That's great. So cultures were sent because the white blood cell count was going down despite the persistently cloudy dialysis, which is a little bit unusual to tell you the truth at this point in time. The white blood cell count was going down. There was no growth to date. They decided to continue the current treatment and bring her back in a few days. So she was brought back again in 2 days. And this time, her fluid was still cloudy. Her mental status was still about the same, maybe a tiny bit better. For the family, again, just kind of saying in her orientation and ability to carry out tasks independently. And the dialysis was again cloudy. And so they again sent fluid, and the white blood cell count for this one was 700 and now had 76% neutrophils. In this setting, typically we check a bank trough to make sure that our antibiotics are appropriately reaching the bloodstream, even though they're delivered intraperitoneally, and the bank trough was 10. In that setting, her bank dose was increased and she was just continued on the cefepime. Cultures were reviewed again, and the prior cultures had been no growth to date. So they decided to once again repeat bacterial, fungal, and then this time added on AFP cultures. That was very astute, whoever had noted that the first time. And perhaps now is a good time to kind of pause and talk about the different
Perfect.
types of peritonitis
Sure.
that we evaluate for as well.
Yeah, perfect. Yes, so Dr. Lee, what do you think? How should we make progress? Because you already predicted this.
So the strictest criteria for peritonitis, are white blood cell. So there's the lab findings, which is white blood cell count total greater than 100 cells per cubic millimeter with greater than 50% PMNs. Clinical findings for peritonitis, which are like abdominal pain, cloudy dialysate, other physical exam findings, etc. And then a positive bacterial culture. So usually you need at least 2 out of those 3 to diagnose peritonitis. In the very beginning, she was maybe 1.5, kind of borderline, but still concerning enough and close enough with that you definitely should still be treated. Yeah, she definitely meets those criteria on day 4. Yeah, usually as you're following the consecutive days, it's good to look at the white count, make sure it's coming down. That's a sign that your treatment is working. And yeah, usually you look at the fluid too. Technically, by day 5, which we don't have yet, but even day 4, it's close enough to day 5 that this is concerning. If the white cell count is hasn't completely resolved or it isn't at least downtrending, and they still have clinical findings for peritonitis, then we call that refractory. So that's if there's still a high white blood cell count in the cell in the dialysate effluent after 5 days of therapy. Similar to refractory, there's other different types of peritonitis that can be considered worrying or treatment resistant. So refractory, if the cell count still hasn't improved by 5 days. Recurrent is if they get better after 5 days, but then within a month, they get peritonitis again, but it's something different. And that might be concerning for, I don't know, ongoing gut translocation, or their technique isn't safe. Maybe they're not having sterile technique. Relapsing peritonitis is another type where they improve within the first 5 days, but then within a month, the same organism grows again. And then that would be concerning for example, inadequate source control. And you can really look for imaging or looking to see where this infection is coming from. And then the last thing we think about for treat peritonitis management Repeat peritonitis is if they get better and then more than a month out, they have another peritonitis event that is the same organism again. And then similarly, you might be worried about lack of source control or whether this technique is sterile or not. But yeah, this person, I'd be pretty concerned that they're heading towards refractory peritonitis. And that one, you would look really closely to see what the infectious organism could be and look for fastidious things like we've already been talking about. And then also get imaging like CT abdomen pelvis non-con, or at least a KUB, like an X-ray. And you would consider catheter removal too. Because one possible concern is that in someone who's having worsening peritonitis despite antibiotics, either the antibiotics aren't covering your organism, like it's something that you haven't covered for yet, or you don't have adequate source control, like the catheter is infected and is a nidus of infection, and the only way to manage it would be to remove it.
Perfect. Thank you so much, Dr. Lee. And I wanted to ask you that when we are going for imaging, are there any particular things that we are looking for which can guide us forward?
Yeah, so imaging, you can look for a nidus of infection in their abdomen, like an abscess hiding somewhere. It might show colitis as a possible infectious source, ongoing gut translocation. In particular, you would want to look around the PD catheter site and make sure there aren't any, there isn't any pericatheter like fluid stranding concerning for inflammation, or fluid collections or abscesses concerning for an infection. If you saw any signs of infection around the PD catheter site in someone with refractory peritonitis, someone who is having ongoing worsening symptoms by day 5, that person would definitely need the PD catheter removed to make sure that you have adequate source control.
Great, that makes sense. So then let's have 2 more days of data.
All right, I think that'll actually take us to the end. So that'll be good. So the patient is actually not seen back. They call in around day 6 or 7 that she's having new diffuse crampy abdominal pain. And so the decision is made by her nephrologist to just send her into the hospital for further management. Their first thing they do is, again, repeat the cell count and cultures, and the cell count comes back at 600 with 95% neutrophils. They do go ahead and get that imaging that Dr. Lee had wanted. A CT, they did actually do with and without contrast, which we can talk about a little bit more in a peritoneal dialysis patient. Probably not ideal, but we were worried at this point, given the concern for this ongoing infection. The CT showed a small fluid collection at the PD catheter site, and so ID was actually consulted during that admission for refractory peritonitis. And ID recommended sending a PCR for bacteria and mycobacteria in addition to the cultures that were already sent. IR was then also consulted for PD catheter removal, and she was transitioned onto intermittent HD. As an aside, on intermittent HD, she continued on the vancomycin for a while and actually developed cefepime neurotoxicity, as is not uncommon for our dialysis patients as well. So she had to be switched over to ceftazidime and was continued on vanc with proper vanc dosing. At that point in time, when she was ready for discharge, her abdominal pain had improved. The cell counts were somewhat downtrending. I actually didn't write down the exact number. And still nothing was growing from any of her fluid from the culture perspective. So they decided to treat her for culture negative peritonitis, which is an empiric 2-week course of antibiotics after the PD catheter had been removed. And then I can go on to day 21 where we actually get a diagnosis if we want to at this point.
No, I think we can wait for a
Okay,
few
we'll hold
moments
off then.
Thanks for all the data and keeping us on the edge of our seat, because we are presenting the data in the form of days. So we are like, okay, now what's going to happen next? Okay. So Dr. Lee, it seems like that you seem to have a blueprint with you of how this case is going to unfold, because you already predicted again that while this patient is moving towards refractory peritonitis. So now it looks like that is where we are, and the imaging findings also is suggesting of what you were hinting earlier, that there is some fluid collection. So now how to make the progress and how to interpret these findings?
Yeah. So yeah, if you find a fluid collection around the PD catheter site, you won't get cure until you have adequate source control, so the catheter would need to be removed. The white blood cell count, yeah, you'd want to see the white blood cell count downtrend after the catheter is removed, to ensure that now with adequate source control, you're treating, you have the correct antibiotic coverage. If it does and she's clinically improving, that's great. Then you've found your source. It was refractory peritonitis because you needed the source control of the PD catheter removal. You know, the imaging with contrast is interesting. We get asked all the time in nephrology, is it safe to give IV contrast for this patient? Or even MRI with contrast. So I'll get on my soapbox. So iodinated contrast with CAT scans, can cause a transient kidney injury from a mixture of the osmotic load itself. It's a very high osmotic load. And then two, it can transiently decrease blood flow to the kidneys. In patients that are already on dialysis, if they're still peeing, and this has mostly been shown in patients with peritoneal dialysis, if they're still peeing and they're still making urine, it's nice to preserve their residual urine output as much as possible because they rely on that to help get their clearance, like we were talking about earlier. So you have to be cautious balancing the risks of potentially worsening their residual renal function with the need for diagnosis with imaging. For this patient, if she was still peeing a lot, for instance, you might, depending how urgent she's looking clinically, you might consider CT non-con first and then CT with contrast if that's not helpful. If you can make a diagnosis without contrast, then you can potentially skip the contrast. That's nice. If someone clinically needs a CTA and it's going to be time sensitive and will change management, they should just get the contrast, and you can manage the potential fallout of decreased residual renal function, AKI, later. Because when contrast-induced injury does happen, it's usually pretty rare, and normally it's self-resolving with just time. Yeah, and then this is completely unrelated to this case, but just so all of you know, MRI gadolinium contrast is a different kind of contrast. Gadolinium in patients with advanced CKD and impaired renal function, there was a concern that it would dissociate and deposit in organs and lead to organ failure, nephrogenic systemic fibrosis. Depending on whether or not you have the newer gadolinium agents, type 2 gadolinium, available at your hospital, there are no reported cases of type 2 gadolinium associated organ failure, but many places are still cautious. And you definitely need to still be cautious if you'd only have type 1 gadolinium. And in general, to help minimize these risks, our institution's policy is for patients on dialysis that need MRI with gadolinium contrast, we do hemodialysis within 24 hours. Recognizing that type 2 gadolinium has no cases reported, but you want to avoid it. Okay, just an aside. Yeah.
Right. That's great. Thanks for highlighting the difference between the gadolinium and the iodinated contrast agents. We often face this problem when we are trying to order the test and we never recognize this subtle difference which exists. So thanks for that. So Dana, we are ready for the final reveal.
We get to the end. So she's in the outpatient setting. The PCR actually is what ended up resulting. The cultures continue to stay negative. Nothing ever grew from any of those, but the PCR that was recommended by the infectious disease team actually resulted positive for TB. It took 13 days to return. So she had actually almost completed her empiric therapy. At that point in time, she got a chest x-ray followed by a CT chest that didn't have concerns for any sort of active TB. However, she couldn't complete the sputum rule out. So she was treated for active TB because they couldn't prove otherwise. And so she got isoniazid B6 and then rifampin and pyrazinamide and ethambutol for 2 months, and then transitioned to the isoniazid B6 and rifampin for another 4 months. And currently she's on hemodialysis while she's undergoing this therapy. However, there's still hope to transition her back to peritoneal dialysis, and that's what she and the family wants, even despite kind of this very long course after she's completed treatment.
Wow. What a wonderful ending. And Dana, do you have any further piece of information as to how patient was doing in the outpatient setting, or like everything went well eventually?
How the patient is doing now?
Yeah.
So she's still on HD. I don't believe she switched
Uh-huh.
back to PD just yet. She's doing okay on HD. I
Perfect.
think it just kind of highlights how much our patients oftentimes
Right.
prefer peritoneal dialysis and the independence. She's tolerating HD fine, but just is looking to get kind of her independence in her life back with that. I think she's not having any side effects from the treatments either, but it's been a little bit since I've checked in on her.
That's good. Perfect.
Not my primary patient when I was
Right. Right.
working with another colleague.
Sure. So, Dr. Lee, what do you make of this case? Do you think are there any subtle points that we should have caught earlier in the case to make this diagnosis more efficiently?
You know, I guess it's interesting that after the catheter was removed, her white blood cell count and the fluid started downtrending. That does sound like there was a catheter-associated infection as the peritonitis, partially contributing to the peritonitis too. But yeah, with the culture as negative and positive TB PCR, it definitely makes sense to treat for TB peritonitis. You know, it is something that often has a delayed diagnosis. 16 days when it was drawn on day 5. So it was diagnosed after around about 3 weeks. Honestly, earlier than a lot of TB peritonitis diagnoses. Sometimes it can take up to a month or two, just because it isn't always on people's differential. But yeah, I think for this person, the key is that in her clinical course, she wasn't improving after a few days on treatment. So you really want to spread out your differential and look for what might be causing this problem. And then, yeah, with her history of prior TB, that would be like on day 3 or day 5, when you would be sending the AFB cultures in TB PCR. Yeah.
Perfect. So that was a phenomenal session, Dr. Lee and Dana. Thanks for guiding us through this case, and we enjoyed a lot learning the case. And Dr. Lee, I wanted to ask that before we end the meeting, are there any key summary points that we should take away from this case, like 2 or 3 teaching points?
Yeah, I would say one big teaching point is always consider peritonitis on your infectious differential for someone on peritoneal dialysis for their ESRD. And then 2, the diagnosis for that is clinical findings, abdominal pain, cloudy dialysate, other signs of infection, laboratory findings, cell count greater than 100 or greater than 50% PMNs, and then microbiology lab findings, positive culture. And then the last thing is, if you're a primary care physician, for instance, and you have an ESRD patient on peritoneal dialysis, and you plan a prolonged antibiotic course, like say for pneumonia or something, don't forget to give antifungal prophylaxis for those patients.
Perfect. That's a very fitting way to end it. You summarized everything, and these are the key points that I would also be remembering when I'm taking care of such patients in the future. And then I was also interested in knowing that how it was like for you to take care of this patient through this journey, that patient was altered all through and through, and how did you reach out to the family, right?
There's also a language barrier. So on top of this, I was covering for a colleague for most of the time that I was seeing her. So I didn't have an extensive history of sort of what her baseline mental status was. And so a lot of it was kind of trusting what the family members were telling me, and then also relying on my PD nurses who knew her actually really well. The PD nurses in the outpatient setting are phenomenal, and they're always happy to help answer questions about like how patients have been doing historically. And typically someone has to be available 24/7. So that was hugely useful in sort of taking care of her. And getting her started. It was such a bummer to have to call her and tell her she needed to go to the hospital like that. I felt really bad about that. We like our PD patients to be outpatient for so long, but I'm glad that we did in hindsight and we're able to get ID involved because we don't always. So it was rewarding that something finally came back. My colleague had come back by that point in time to get to make the official diagnosis. But yeah, frustrating at the time when you're like, I don't know what else this is, but rewarding when it finally comes back with something that you can treat so you can get her back on peritoneal dialysis.
That's great to know. I'm so excited to know that patient did better eventually, thanks to the comprehensive efforts led by you and your team. And once again, thank you, Dana and Dr. Lee, for taking your time out and coming to this session. We highly appreciate it. And we can't wait to have you back with us in the future with another exciting case. I also wanted to thank Maddie for organizing this wonderful VMR, inviting everybody. Thanks to Gia and Teresa for helping with the scribing and teaching points as well. And thanks to everybody for joining us. We'll see you next time, guys. Take care.
Thank you.
Bye.
Bye.